We are live now, ma'am. Good
Yes.
evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Pinnacle News Series, Episode 11. In association with Jammu, Kalyani, Himatnagar, Udaipur, and Guntur OBGYN societies. So it's my privilege to introduce the MOC of today's webinar. So before that, let us start the webinar with prayer song. It's my privilege to introduce the MOC of today's webinar, Dr. Madhumita Arun Karthik ma'am. Ma'am is consultant and obstetrician and gynecologist and reproductive medicine specialist in Salem and also treasurer of Salem chapter of Tapisar. Yeah, I welcome
Thank you so
you.
Thank you. So, I welcome all the delegates and faculty today for the 11th episode of Pinnacle News Series. This is a very unique webinar series which unites all the four corners of our country, and it's organized by Professor Dr. Sampath Kumari ma'am. Can I have ma'am CV, please?
No problem, Admita. We'll start.
I'll just give a short. So, ma'am is a professor and HOD of Shri Muthukumar Medical College and Hospital at Chennai. She is also a past vice president of FOXY and Senate member of Tamil Nadu Dr. MGR Medical University and national corresponding editor of Jogi, founder secretary of Tamil Nadu Federation of Obstetrics and Gynecology, and also she is the president of OXY. And she's also the retired deputy director of Institute of Obstetrics and Gynecology of Madras Medical College, Chennai, and past chairperson of FOXY Adolescent Health Committee and President Board of Studies of Tamil Nadu MGR Medical University, and she received the first ICOG Distinguished General Council Member Award and also Chairperson of Women's Wing, IMA Chennai South, and IMA National President's Award and IMA Tamil Nadu State Bench Award she has received. Over to you, ma'am, for the welcome address.
Thank you, Dr. Madhumita. I welcome all of you for this Pinnacle 11 News. This is the webinar which is conducted every month from second Thursday and fourth Thursday. Second Thursday being the obstetric topic and fourth Thursday being the gynec topic. We include societies from North, East, West and South. So it is mentioned as news, Pinnacle News. I welcome the societies, Jammu OBGYN Society President Dr. Aarti Sharma, Secretary Dr. Manjula, and Himatnagar Society President Dr. Sarfaraz, and Secretary Dr. Vishang, and Kalyani Society President Dr. Anita Rai, and sorry for if I am pronouncing it wrongly. It is Suvabrata, Secretary, and next Udaipur Society President Dr. Prakash and Secretary Dr. Pradeep, Guntur Society Dr. Venkateshwara Rao, President, and Dr. Uma Shankar, Secretary. So now we have 5 societies. And I thank Dr. R.C. Sharma, sir, who has accepted to be the chief guest. And guest of honor being the Prakash Jain, sir, Venkateshwara Rao, sir, and Vishak Patel, sir. We have the great talk, wonderful talk by Dr. Arun Arora. He will be talking on decoding adolescent PCOS. As all of us know, more than 35% of the population is adolescent. So he will be talking about the decoding adolescent PCOS and chaired by Dr. Anita Rai and Dr. Manjusha. Then we have the panel. Again, the PCOS. In infertility, nowadays, the common cause being the PCOS. We have the panel with the PCOS and infertility. Moderator being the Dr. Sarfaraz and expert Dr. Uma Shankar. And I welcome the panelists Dr. Rohit Patel, Dr. Safan Doshi, Dr. Syed Hussaina, Dr. Avir Sharkar, Dr. Anamika, Dr. Suobrata Sharkar, and Dr. Ginny Gupta. And I welcome our MOC, Dr. Madhumita and Dr. Radhika. Now we will go with the inauguration ceremony, and I welcome Dr. R.C. Sharma, sir, for his chief guest address. Shahiti, can I have the CV of Dr. Sharma, sir?
Hanji, madam. Yes.
Yes, sir. R.C. Sharma, sir, is the president of Jammu OBGYN Society. Welcome, sir. We need
Thank
your
you, madam.
blessing for this webinar. Yes, sir. Sharma, sir, can you tell
Ji,
few
madam.
words?
Yes, madam.
Yes, sir. Sharma, sir, sir, with his blessings, we will start the scientific section. Guest of honor, who are all there? I think, I don't know whether Dr. Venkateshwara Rao, Dr. Prakash, Dr. Vishank, anyone is there?
इस पे टैप करके स्टॉप हो जाएगा
अच्छा ये करना बस.
आप बोल रहे हो ना अब डन स्पीकिंग
Sharma, sir,
Yes, madam.
can you talk few words about the and bless the webinar?
Madam, this is once I was a medical student. It was not a entity PCOS, and once I started doing a MD post graduation.
Yes, sir.
It was only a steel Leventhal syndrome, and nothing more and nothing less. There was a nowadays.
Yes,
As
sir.
the time is passing and daily in our OPD, we are seeing a lot of girls coming with whether they are adolescent or they are married or unmarried, coming with the different problems like amenorrhea, hirsutism, obesity, and inability to conceive. This I wonder that how this incidence is is increasing, and day practice we are getting all these patients, and in adolescent girls also they are coming also with the problems with obesity and amenorrhea. Amenorrhea in just this is a problem nowadays. So this is my practical experience in my OPD. So
Thank you.
let's talk and see, and then we will elaborate what is happening. Okay, ma'am?
Thank you, sir. Thank you so much, sir. Now we'll
Okay.
go with the scientific session. Can I have the CV of Dr. Anita Rai and Dr. Manjusha? I think all three of them have not yet joined.
Okay, ma'am.
Dr. Anita Rai is an associate professor in JNM Hospital, Kalyani, and the president of Kalyani Obstetrics and Gynecological Society. Her field of interest is high-risk pregnancy and urogyne. Can I have the CV of Dr. Manjusha? Dr. Manjusha is consultant gynecologist in Jammu and Kashmir Health Services, 25 years experience in the field of OBG, Joint Secretary IFS, presently Secretary of Jammu OBGYN Society, area of interest, safe motherhood and high-risk pregnancy. Dr. Anita, madam, can you introduce the speaker, Dr. Arun Arora?
Yes, ma'am, I can.
Yes, ma'am.
Dr. Arun Arora had been the ex-HOD of GMC Udhampur. He is a visiting professor, fellowship ICOG, national advisor to Indian Fertility Society. He is also the advisor of Jammu Obs and Gynae Society. He is the president of NIGF Jammu, president of SOFC Jammu, founder secretary IFS Jammu. He has delivered more than 100 academic lectures as guest faculty, contributed many chapters in postgraduate books, inventor of original technique of cesarean in deeply engaged head. That's a big, big line of accolades. Welcome, sir.
Thank you, madam. Thank you for the kind words. So, thank you, Sampat madam, for giving me this opportunity of delivering this lecture. So I don't know whether I'll be really decoding the thing or making everybody confused after this lecture, because still many questions are there, which even I do not know. So let's see whether we are able to really decode or confuse people. So can I share my screen?
Yes, sir. Rahiti, can you make him as a host?
All the panelists have access to share the screen now.
Yes. Arun sir, you can chat.
Yes, madam. Yes. Just one sec.
Okay.
Is it full screen, madam, or?
No, sir, you have to go to slideshow.
Is it okay now?
Yes, sir.
ma'am.
Yes,
Yes, sir.
Yeah. Thank you so much. So, like Dr. Asi said, so we started with Steen Levinthal way back, and then we moved on to different criteria. So let us see why this entity called as adolescent PCOS is still, troublesome. Is it really a misnomer? One, that is the question. Or have we hyped it? As he was telling, like every, second girl, third girl is coming up with PCO. Have we hyped this entity? That is a big question. So let us try to decode what is there. I'll take you through this for another 20 minutes. So let's first focus on diagnosis part. This is diagnosis of polycystic is based on criteria. And why we require a criteria? Because any heterogeneous disorder, one particular single parameter is not strong enough to make a diagnosis. All right. We take the example of, say, ultrasound findings of polycystics. 20% of women, I missed something. 20% of women with PCOM have PCOS. PCOM is absent in approximately 20% with PCOS, and PCOM is present in approximately 20% without PCOS. So this is how we started with in 1990, National Institute of Health, NIH gave this criteria. This group was from US. They gave the criteria that we have to have two parameters to make a diagnosis of PCOS. One was oligoanovulation, and second was clinical or biochemical signs of hyperandrogenism. But this was a US group. Then the European group was not happy with the exclusion of ultrasound findings of polycystic ovaries, right? And in 2003, they gave this criteria which is called as Rotterdam, which we are following now. PCOS is diagnosed if two of the following three criteria are included: oligoanovulation, clinical androgenism, clinical or biochemical signs of hyperandrogenism, and presence of polycystic ovaries. Then in 2006, Androgen Access and PCOS Society, they changed slightly the criteria, because then what they did was they kept hyperandrogenism as a compulsory parameter. So it has to be there, and associated with that, one has to have either ovarian dysfunction in the form of oligoanovulation or a presence of polycystic ovaries. So now what are the challenges, especially in terms of diagnosing in adolescent PCOS? Because features of normal pubertal development overlap with adult PCOS diagnostic criteria, hence caution should be taken before diagnosing PCOS without longitudinal evaluation. So we have to, over a period of time, if we find that these changes remain or they exacerbate, then we probably think this to be because there is a strong overlap. In addition, The rising prevalence of obesity, as Dr. RC was telling, rising prevalence of obesity in pediatric population may compound insulin resistance in girls predisposed to ovarian hyperandrogenism, leading to younger age of presentation and more severe phenotype. So these are the challenges. So what happened was then the international evidence came and for adolescents, and they give this updated Rotterdam criteria. They said in 2018, they said OA and HA, they have to be there. They avoided PCOM for PCOS diagnosis. So now only two parameters were there, oligoanovulation and hyperandrogenism. So practically, we came back to the original criteria. If we compare this with the 1990 NIH criteria, it also had the same thing, no? Oligoanovulation and clinical or biochemical. So updated Rotterdam criteria is probably nothing but reverting back to a 1990 criteria, which is applicable only for the adolescents. And for the adults, we have either the AI Society or Rotterdam criteria, whichever you follow. All right. Now, this is, however, this recommendation is based on expert consensus with limited evidence on most accurate diagnostic approach in adolescents and on the natural history of PCOS phenotype over time. It remains unclear if this particular updated criteria really captures adolescents with PCOS who are at the greatest risk of long-term complications and would benefit the most from a lifestyle preventative interventions. So this is the criteria. 2020 again we came up with. Then we defined what is the irregularity and ovarian dysfunction. This is again very important. And as far as hyperandrogenism is concerned, this is again important. We'll get into this slightly later on a detailed this thing. So then this came in 2023, which is again based on 2018 guidelines. International evidence-based guidelines came from all the Monash University, ASRM, European Society, ESHRE, European Society of Endocrinology and ESHRE. So then they defined these entities, no? So first off is, how do we define irregular cycles or what are the irregular cycles? Normal in first post-menarche as part of a pubertal transition. So any irregular cycle in first post-menarche is not taken into consideration. From 1 to 3 years, so any cycle which is less than 21 days or more than 45 days is taken into consideration. 3 years post-menarche, this changes to 21 days and 35 days. From here, it was 45 days. Now it has gone to 35 days in 3 years post-menarche, or we have less than 8 cycles per year. Then in 1 year post-menarche, any cycle which is more than 90 days, we consider this as irregular cycles. Or we have a primary or amenorrhea by age 15, or if it is more than 3 years post-hilarchy amenorrhea, then we call this as a irregular cycle. Now, when irregular menstrual cycles are present, a diagnosis of PCOS should be considered and assessed according to these PCOS guidelines. For adolescents who have features of PCOS but do not meet the diagnostic criteria, an increased risk or at risk could be considered and reassessed at or before full reproductive maturity, usually 8 years post-menarche. Now, what is the ovulatory dysfunction can still occur with regular cycles, and if anovulation needs to be confirmed, it has to be confirmed by serum progesterone levels from day 20 to 24. This is the recommendation now. Now, why these criteria came? Because see, we see 1 year post-menarche, we have around slightly more than 80% which are anovulatory cycles. Red denotes anovulation. 3 years post-menarche, we have around 60%. And 6 year post-menarche, we are left with just 20-25%, which are anovulatory cycles. The cycle length also varies, if it is more than if in 80 to more than 80%, it is more than 40 days. And then we have, that is how we came up with the in ovulatory or irregular menstrual cycle criteria. Now, coming on to the second part, which is important, is hyperandrogenism. Now, before I really go to hyperandrogenism, I just want to explain one condition which is called as a functional hyperandrogenism of puberty, or what we call as a transient hyperandrogenemia of puberty. So this is a temporary phase which is occurring during puberty, and it over a period of time it goes away, right? So in this, Ferriman-Galway score is not very useful because this score has been standardized for white women who are more than 24 years of age. Now, coming to how do we diagnose hyperandrogenism, which is PCO related? Hirsutism defined as modified Ferriman-Galway score 4 to 6. Some people say more than 8, but usual recommendation is anything more than 6 is important, and or severe acne or inflammatory acne more than 10 on face. And rarely we have alopecia also. So, but one recommendation is again now coming up that in adolescent, Ferriman-Galway score of even less than 6 can be considered. So this is the Ferriman-Galway score. What modification in original was? Original had the counting of 11 sites. 2 sites have been deleted. Now it is from the 9 sites only. The forearms and the legs part has been excluded now. So now this is Ferriman-Galway modified score. Now coming on to acne, we have either the severe acne, because mild acne is again a part of pubertal development. We have a severe acne, or we have a ulcerative type of acne, and it should be more than, say, roughly 10 on the face. We then consider this as a part as a sign of hirsutism. Alopecia, some people say again it has to be, has some importance, but not many studies are there which recommend alopecia as a criteria for hirsutism. Now, how do we measure biochemically this hyperandrogenism? In females with irregular cycles, yet without clinical hyperandrogenism, in these cases, we will do a biochemical test or laboratory test. In most adolescents, androgen levels reach adult ranges at around 12 to 15 years of age. Total or free testosterone can be tested. Free testosterone or free androgen index can assist with diagnosis, although no cutoffs have been given. If testosterone or free testosterone is not elevated, healthcare professionals could consider measuring androstenedione and DHEAS, noting that they have a poor specificity and greater age-associated decrease in DHEAS. Then the most important part is laboratories should use validated, high-accurate tandem mass spectrometry, liquid chromatography, LC-MS assays for measuring total testosterone, and if needed for androstenedione and DHEAS also. But unfortunate part is that these high-end investigations or facilities are not available in all hospitals. So it again becomes difficult for us to really document biochemical hyperandrogenism. Again, another part is any woman who is using COCP, combined oral contraceptive pill, it is really difficult to assess biochemical because the SHBG is increased, which reduces gonadotropin independent androgen production. If patient is already on COCP, then 3 months withdrawal is required before we test for biochemical and hyperandrogenism. A word about free androgen index. Typical values in a women are 7 to 10. It's a ratio between total testosterone and SHBG multiplied by 100. The concentration of testosterone and SHBG are normally measured in nanomoles per liter, but there is no unit for FAI because it is a ratio. Majority of testosterone in the blood does not exist as a free molecule. Instead, around half is tightly bound to SHBG and the other half is weakly bound to albumin. Only a small percentage is unbound, under 3% in males and less than 0.7% in females. Since only free testosterone is able to bind to tissue receptors to exert its effects, it is believed that free testosterone is the best marker for a person's androgen status. However, free testosterone is difficult and expensive to measure because it requires a time-consuming dialysis steps, and many laboratories do not offer this service. So that is why we do a FAI. A word about AMH, just to say that AMH is not recommended in adolescents as anything, because 2023 guidelines added AMH as a diagnostic criteria or a helping criteria in diagnosing adult PCOS, just to negate that thing that this has no value in adolescents, this particular thought. And usually, because it usually peaks between 20 to 25 years, so it has no value in adolescents. Now, the next question is, is the incidence high? Or what Dr. Ramesh was telling, that no epidemic, every third patient is coming up. Now, updated in a study in 2020, they said that using updated Rotterdam criteria, only 18 to 13% of females had, incidence of adults also, and same for the adolescents also. Another study in International Journal of Reproductive Medicine and 2029, they said that they applied different criteria. At Rotterdam, it was 11%, and based on NIH criteria, it was 3.39%. So when I'm talking of NIH criteria here, it indirectly means updated, because it is similar to NIH criteria. And then it came to be just 3.39%. This means out of 100, we'll just have 3 or 4 100 adolescents, we'll just have 3.3 adolescents. And based on Androgen Access Society, it was 8%. So anyway, it is not that something like epidemic of PCOS occurred, and probably we are overdiagnosing. Another study in Lucknow, India, we had just 3.7% women, girls who are had polycystic ovaries. Now, coming on to the next controversial story, is it a misnomer? Why I call this as a misnomer? Because a high prevalence of polycystic ovarian morphology may be observed during adolescence, so PCOM is not a useful criteria as told earlier, so it is out of picture. In addition, since PCOM is not clearly associated with hyperandrogenism during this period of life, the term polycystic ovary syndrome during adolescence creates confusion and may be misleading. So, where does ovary stand? One, it is not showing any concrete evidence of PCOM, because at this point of time it is not reliable. Secondly, it is not really associated with hyperandrogenism also, because this really needs a in-depth study, that how much of androgen is really coming from the ovary, because only what the literature said is only 25 to 30% of androgen comes from ovaries. Rest comes from peripheral conversion or adrenals, right? So if ovary is nowhere in the picture, why name it as a polycystic ovary? So is it time to change terminology of adolescent PCOS? This is a big question. Probably yes. This terminology is indeed being reconsidered by experts. Since puberty naturally causes hormonal fluctuations, diagnosing PCOS in adolescents is challenging, and some researchers argue that the term may lead to overdiagnosis or unnecessary anxiety. Recent guidelines also suggest that adolescents with only one diagnostic feature should be labeled as at risk rather than being formally diagnosed with PCOS. This approach allows for symptom management and follow-up without prematurely labeling a condition that may evolve over time. Now, what will be the impact if we change this terminology? We will be reducing overdiagnosis. By refining criteria and terminology, adolescents who are at risk can be monitored without prematurely labeling a lifelong condition. We'll have better treatment strategies, because a more precise name might encourage targeted approach, because one size fits all PCOS diagnosis is not there. Less psychological risks, because avoiding an early diagnosis might help reduce anxiety and stigma, because every second girl she goes through Google and finds out that there is something called as PCOS, and then she comes to you and says that I have a PCOS without really having any symptom of PCOS. Probably some sonologist has labeled this as just one finding of PCOM, which as a something on ultrasound. So more personalized follow-ups will be there if we rename the, change the terminology. Now, what are the proposals which have been, one is at risk of for PCOS. This is the one term which has been suggested even in recent guidelines. Second is hyperandrogenic anovulation. Some experts propose this term to emphasize the hormonal imbalance and ovulatory dysfunction rather than the ovarian morphology, because hyperandrogenic anovulation means this satisfies both the criteria, all right, which are in their updated Rotterdam. And third is a ovarian dysmetabolic syndrome. This name highlights the metabolic aspects of PCOS, which are often overlooked in the current terminology. And then metabolic reproductive syndrome, another alternative that focuses on the systemic nature of PCOS rather beyond just ovarian dysfunction. These changes aim to improve diagnostic clarity, reduce stigma, and encourage personalized treatment approaches. Now, what are the challenges with renaming adolescent PCOS? One, there will be a diagnostic uncertainty because it will be harder to distinguish in between normal development and actual PCOS. It will be difficult for medical professionals who would require new clinical adaptations and new clinical updated diagnostic criteria. So we have to again go back and find or define new criteria. Patients again have to be made aware and education. They may struggle to understand the implications of a new term, leading to confusion about symptoms and risks and management because they have been accustomed to listening to the word PCOS. Research and data standardization again will be difficult because when we do a long-term research comparisons, we look into the previous data or previous studies where there will be a PCOS, and then we'll not be able to really standardize that data. Insurance healthcare policies will again be difficult because a new term might affect insurance coverage. Despite these challenges, refining the terminology could help reduce stigma, improve diagnosis, and encourage personalized treatments. Now, how do we really address these concerns? We have to update guidelines, like latest guidelines said at risk for PCOS. Then we have a shared decision making. They can involve the adolescents in discussions, avoiding overdiagnosis. Experts stress that PCOS morphology should not be used for diagnosing in adolescents. Long-term monitoring, adolescent symptoms are advised to undergo regular follow-ups to track hormonal changes and metabolic health. Multidisciplinary care management strategies now include lifestyle interventions, psychological support, and tailored medical treatments. Except for the part that girls are girls and they come to a gynecologist. Otherwise, where are we really involved in terms of having a hyperandrogenism? Except for that, she comes to us for irregular cycle. That is part which we are concerned with. But for any long-term management in terms of long-term complications, other people can also be involved. These efforts aim to balance early intervention with avoiding unnecessary labeling, ensuring that adolescents receive appropriate care without premature diagnosis. Now, what is the opinion? Conclusion comes to this is the lessons we have learned. There has to be a need for careful approach and diagnostic criteria to provide timely diagnosis during adolescence. Diagnostic criteria should avoid overdiagnosis that causes unnecessary concerns. Close follow-up of adolescents at risk of PCOS who do not fill the diagnostic criteria. Education of healthcare professionals about the diagnostic criteria. Multidisciplinary approach. If adolescent fulfills only one of the diagnostic criteria, they may be considered at risk, as previously told. Some experts suggest labeling adolescent as at risk rather than diagnosing PCOS outright, allowing for symptom management and reevaluation over period of time. Now, how do we manage? A word about management. Lifestyle interventions like exercise and diet management. Not going into really details, but exercise is one important factor. One may not really stress on weight control measures. Even exercise in itself leads to a decrease in hyperandrogenism. Combined oral contraceptive pills may be used in adolescents to take care of their irregular cycles. Metformin can be used alone or in association with combined in association with COCP. It has been shown to be more beneficial. Talk a word about inositols. Although new guidelines do not recommend inositols, but they say they say it is not that harmful also, so one can consider. But as far as I am concerned, since inositol or these are neurotransmitters, so what I always feel is that giving inositols may take care of the psychological or anxiety issues in these young girls. So inositol at any point of time is not a bad story. So cosmetic therapies like laser and light therapies can be considered. So another question is now come is, what will happen if we delay the diagnosis? While some experts advocate for careful monitoring before confirming a diagnosis in adolescents, waiting too long can result in unmanaged symptoms and increase health risks. So now what are the unsolved questions? Which subset of patients are really at risk of long-term complications? Am I supposed to tackle all at-risk patients and follow them up for a long period of time? Or I can find one subset of patients who are really at risk of long-term complications, so I can follow only those patients. I wish I knew. If somebody knows, please let me know. Thank you so much, madam. Thank you, everyone. So your vote matters. I'm contesting for governing council member for ICOG. I need support of all those people who are ICOG fellows. So your vote really matters. Thank you so much.
Thank you, sir. All the best for your election. Really, I have forwarded in our Tamil Nadu group also.
Thank you,
Yes,
madam.
sir. Thank you very much for the wonderful talk, sir. Now the adolescent PCOS is really, as you told, it will be diagnosed in a large number, or it may be missed and it will end up in the metabolic syndrome. So lifestyle changes is the treatment, main management for the adolescents. Thank you, Arun, sir. Now we will go with the interesting panel, PCOS and infertility. Dr. Madhumita, are you there?
Yes, ma'am. Yes, ma'am.
You can introduce that.
So
Moderate.
next, we move on to a second session, which is a very informative panel on PCOS and infertility. For the panel, we have our esteemed moderator, Dr. Sarfaraz Nawaz Qazi, sir. Can I have CV slide, please? Sati? Yeah.
Sashiti Umashankar, sir.
And we have
You may change to
Join
Sarfaraz, sir.
yes, ma'am. Next.
Sashiti? Yes.
Sati, can I have Qazi sir's CV slide?
Sarfaraz, sir, now they have posted.
Yes. So, sir is an onco-gynecologist and director at Nauzivan Women's Hospital at Himatnagar, and he has 20 years experience, and he's done his advanced training in gynec-oncology at Ahmedabad, and he's awarded fellowship in 2024 by ICOG, and he's also done his fellowship in reproductive medicine and his diploma in endoscopy. And we have our esteemed panelists with us today, Dr. Rohit Patel, who's the consultant at Badra Women's Hospital, Himatnagar, and he's also the treasurer of SOGOG 2023 and treasurer HOXO since 2022. Next, we have Dr. Sapan Doshi, who's the consultant at Tulip Hospital, Idar, Gujarat, and past president of IMA Idar, past secretary of HOX, and also organizing secretary of SOGOG 46 at Himatnagar. And we have Dr. Sheikh Syed Hussaina, who's a assistant professor at Shri Muthukumaran Medical College and Hospital, and she has numerous publications to her credit.
Next slide.
Next slide, Sarthi. We have Dr. Avir Sarkar, who's assistant professor at AIMS Kalyani, and sir is also the E-Zone coordinator of Family Welfare Committee of FOXY, and also executive council member of Society of Meaningful Life Management, and executive member of Faridabad Menopausal Society, and also he has numerous publications and social activities to his credit.
We've got
So I
all
think
surprise
we
in
have-
all yours, Madhumita.
Yes.
Yes.
And we have Dr. Ginny Gupta, who's a consultant at Jeevisha Clinic in Udaipur, and she's also done her fellowship in assisted reproductive technology, and she's also an active member of Udaipur Menopausal and Obstetric and Gynecological Society. And we have Dr. Subhadra Sarkar, who is the Secretary of Kalyan Obstetric and Gynecological Society. And we have Dr. Anamika Chowdhury, who is who's done her training in minimal access surgery, and also she's also currently working in Anantya Institute of Medical Science as a consultant obstetric and gynecologist since the past 4 years. Next slide, please. And we have Dr. Akansha Tripathi, the senior consultant laparoscopic surgeon at Udaipur, and she's also the treasurer of Udaipur Obstetric and Gynecological Society and joint secretary of Udaipur Menopausal Society. Next slide, please.
That's all.
Yes. Yeah. Kazi sir,
Hello.
you can share your slide, sir.
Hello.
Yes.
Hello. Good evening, Madhumita.
Yes,
evening,
And
sir.
yeah. And I'm very impressed to see that you are driving and doing your work. Just be careful.
Sir, no, sir. I'm with the driver. I'm not driving.
Okay. That's good. Real seat belt is must after the incidents of Manish sir, as we have
Yes, sir.
heard.
So shocking to hear, actually.
Yeah. He's fine right now. How many panelists are available? Just I want to confirm before sharing my slide.
Dr. Rohit is there. Dr.
Hmm.
Sapan Toshi is there. Husaina is there.
Okay.
Others I didn't see.
So
Anyone
anyone
Yeah.
not
is there?
Coordinator,
Avik
please
Sarkar?
just call for the. I am also seeing only three panelists
Only
available.
three I am seeing. Ginny Gupta.
Doctor-
Pranav.
Dr. Anamika is here, ma'am.
Yes,
Anamika is
Anamika,
there,
can
na?
you please
Anamika,
change your name?
rename,
Uh,
please?
yeah,
Then we have four.
yeah. Now
Sapan Toshi, Husaina.
one more is there. One more
Dr.
doctor
Avir
is there.
Sarkar is yeah, sir. Dr. Avir? Sir. No, it's not the right.
Dr. Avik Sarkar. Anyway, I'll give you a call. You can start. I will give a call.
Okay. Is my slide visible?
Yes, sir.
You have to go to slideshow.
Screen show. Slideshow alone.
Just a minute. Is it okay?
Yes, sir. The slideshow alone.
That
We are able to
first
see
you didn't
the
go to
slide.
slideshow.
Just a minute, ma'am.
Please click on play option, sir. Play slideshow. First one.
Is it okay now?
Are you joining the panel?
Yes, sir. Yes, sir. It's full
thank
screen
you.
now.
We are not able to
It's
see.
full screen,
You
no?
have joined in attendees.
Yes, sir.
Okay. First of all, it was a very pleasant evening here. Atmosphere is very good. There is a chances of low network, so pardon me, this thing happens because winds is going very fast here. Thank you very much, ma'am, for inviting me on this Pinnacle web series. Sampat Kumari, ma'am. Thank you very much for inviting me on this web series. And I'm very delighted to see all my fellow colleagues and seniors from Jammu, Kalyani, Himmatnagar, Udaipur, Guntur, Obstetric and Gynecological Society. This was the first talk was very interesting by sir who is contesting for the ICU. No, Arun Arora, sir. He's contesting for the ICOG committee member, na? Governing counseling member. Sir, we are going to nominate you, definitely. And after finishing this talk, we are jumping for the panel discussion. Maybe 4 or 5 panelists are available. So, Rohit,
5 is there.
Sapan is there.
Rohit, Sapan Toshi,
Okay.
Husaina, Avir Sarkar.
Anamika.
Anamika.
Okay, Avir Sarkar
Avir
also
Sarkar.
joined.
Sarkar, sir.
Okay. So we are going to discuss on basic things of PCOS and infertility. As sir has discussed before that in his topic, it is a complex heterogeneous features of PCOS in all the aspects, including reproductive, metabolic, psychological, and fertility. So directly I'm jumping to the case discussion. With this case only, we are going to cover all the aspect of PCOS and infertility. You can see my slides now, panelists.
Yes, yes.
Okay. Anyone is unmute? Everyone is unmute now? Hello?
Yes, sir.
Yes,
Rohit,
Yes, sir.
yes.
Sapan, Anamika,
Yes,
Husaina,
sir.
Avir Sarkar,
Yes,
all are
sir.
unmute.
Yes.
Okay.
Yes.
So this is the case. A 27-year-old patient with AML of 3 years, trying to conceive since 1 year. Menstrual history is 3 to 7 days, 40 to 60 days scanty period. Mild hirsute, acne is there. Her BMI is 29. Her both tubes are pattern on HSG. His semen analysis is normal for husband. Routine investigation has been done. CBC, RFT, blood group, LFT, HIV, HbC, HCV, urine, everything is normal. Sugar is normal. TSH within normal limit. In USG, uterus is normal, but there are mild PCO-like picture. Her LH-FSH ratio is 3:1. Total testosterone is 60 and AMH is 6.9. So what is the diagnosis? I will ask Dr. Rohit first. Rohit,
Good evening, sir, Rajbhai.
very good evening.
Uh,
It
my
seems like a
diagnosis,
yeah, please.
uh, am I audible?
Again, we cannot hear Rohit.
Hello, am I audible?
A little bit increase your voice.
Am I audible now?
Yeah.
Okay. Good evening, sir, Rajbhai.
Yeah.
As far as I have seen your slides, patient's BMI is
In the
actually
link,
it should be less than 20,
Hmm.
and patient is having hirsutism. So
Yes.
she's having uh, she's definitely having a PCOS, and I would like to.
So first we will stick to the diagnosis. First we will stick to the diagnosis, Rohit. It's okay. Patient is having
PCOS.
PCOS.
PCOS,
Yeah,
yes.
Dr. Avir Sarkar, according to you, what are the criteria for the diagnosis of PCOS?
Sir, there's a Rotterdam's criteria which is followed for the diagnosis of PCOS. According to the Rotterdam's criteria, there's a triad which we generally follow, like there should be features of hyperandrogenism, be it
Yes.
clinical or biochemical hyperandrogenism. Second is in ultrasound, there can be polycystic ovarian morphology. And number three, patient can have menstrual irregularity. So there are actually there are four phenotypes of PCOS. In phenotype
Very
A,
good.
all the three characteristics are present, all the triad is present. In phenotype B, we have generally the adolescent type of PCOS where the ultrasound features are not present, but hyperandrogenism and menstrual irregularity is present. In type C, basically menstrual irregularity is not there, and type B, hyperandrogenism features are not there. So
Very good.
any two of the three criteria must be present for categorizing the patient as PCOS.
First two criteria should be present. US ultrasonography is needed when if there are only one criteria from first two, as per the ASRM guidelines, and you have to exclude the other endocrinopathies before diagnosing the PCOS. Am I right?
Yes, sir. Yes, sir.
Okay. Okay. So this patient is of PCOS. Pathophysiology has been already been discussed. We will skip all these things. Now, why PCOS leads to infertility? What are the pathophysiology which are included in PCOS which leads to infertility? Dr. Hussaina, this for you.
Yes, sir. It's because of the insulin resistance and
Okay.
also because of the altered LH-FSH ratio. And so that is going to lead to anovulation, and that is going to lead to poor oocyte quality. And
Very good.
also, it can, even after the pregnancy, there can be gestational diabetes, hypertension, risk of miscarriage. All this
Very
is
good.
there.
Okay. So PCOS is affecting ovary, PCOS is affecting endometrium, and systematically hyperandrogenism and hyperinsulinemia is affecting the fertility. Okay. How PCOS hyperandrogenism affecting endometrium? Can anybody describe? Anyone from the panelist? Effect on ovulation we understood, but how it affect the endometrial receptivity? Dr. Anamika?
या कॉफी ले आना कहाँ क्या कर रहा है कोई कह जा रहा था
Dr. Anamika?
लिए तूने
Yes, sir.
तेरे को
Yeah.
यार
Yes, sir.
कम को पैसे देने मैंने थोड़े से
Can you explain how PCOS is affecting the endometrial receptivity?
अच्छा और देता हूँ तेरे
Sir, actually, PCOS is a high estrogen condition, and
Okay.
because of chronic anovulation, we have no progesterone available for endometrium ripening. That
Okay.
is the cause. Sometimes we have ovulation, but still we have like pregnancy failure in these cases. And over the time, these patients also have, when patient don't bleed like 2 to 3 months, then we have risk of endometrial cancer. That's why when it happens if amenorrhea happens more than 90 days, we need to give progestins for withdrawal bleeding for endometrial protection.
So overall, the cascade of PCOS, hyperinsulinemia, hyperandrogenism, which leads to the differentiation growth of the endometrial cell, affect the function of the corpus luteum, affect creating the ROS, and which all leads to the impaired endometrial receptivity. Okay. Suppose this patient is obese. If her BMI is, you can say more than 35. So which other factors will be included for her infertility apart from PCOS? PCOS with obesity, how it affects the infertility? Dr.
Sir,
Avi
it will
Sarkar.
okay.
Now you can continue.
Actually, obesity will increase the peripheral fat. So in the
Yes.
fat, there will be peripheral aromatization, and so
Yes.
estrogen level will further increase. So
Yes.
chronic hyperestrogenism will be there, which will thereby alter the once it will alter the ovarian milieu also, as well as the endometrial receptivity will also be impaired. So more chances of a patient having infertility in such cases.
So the cases of thin and lean PCOS, with compared to the obese PCOS, there are more chances of infertility in obese PCOS just because of the peripheral fat distribution. Doctor, our expert is there, Dr. Uma Shankar.
So Uma Shankar sir is not able to join, sir, as he's held up.
Okay, no problem. Now this is the patient. Come back to our original patient. She is not obese. How will you counsel Dr. Sapan? Dr. Sapan?
Hello.
Hello.
Yes.
Yeah, Dr. Sapan. You have seen the
Yes.
history of the patient, na? You have
No,
seen the
I
history of the
just
patient.
came. Yeah, I
Okay.
just came and
For
I have
you, I am
just
sending.
admit.
I am keeping this
Yeah.
slide for you only. This is our patient, 27-year-old. You can see.
Yes, yes,
Sapan?
yes. I am able to
Yeah.
see.
Okay. So this is your patient. Mild hirsute with acne, irregular menses, infertility, try to conceive since 1 year. Other factors are normal, BMI 29, sugar normal, thyroid normal, LH-FSH ratio is 3:1, sonography is
Total
showing
testosterone,
PCOM,
AMS 6.5.
testosterone is 60, AMS 6.5. Now,
Okay. So
how
now,
will you counsel?
so
Patient comes to you.
I would like to do her husband semen analysis first. If it's normal,
Normal, it is
then
normal.
yes, then I will start with ovulation induction first for 3
Directly.
to 6 cycle.
Directly.
Yes.
Anyone differ from the panelists?
Sir, yes, sir. Yes, sir. Can I explain, sir?
Yes, please.
Sir, lifestyle intervention is must in preconceptional counseling, and
Very good.
yes, we will also counsel her about her dietary modifications and
Very good.
all the moderate intensity aerobic activity, like we advise for 150 to 300 minutes, and also muscle strengthening, because the cause is in skeletal muscle. Like we claim like this all this all this I'm sorry, sir.
Yeah, yeah. Continue,
Yes,
no
sir.
problem.
Uh,
Avir
okay,
Sarkar,
sir.
you want to add something?
Yes, sir.
Doctor, yes.
As Dr. Anamika has told, lifestyle modification plays a very important role. Weight reduction and all these things, they will be advised to the patient. And after that, if still she is not able to conceive, then we can like prior to what sir has told, starting of induction, we will also try to check the we will do an HSG for the patient to look for
HSG
the
is
tumor.
normal. HSG is
HSG.
normal.
So here I would like to add the thing is as already patient is having BMI of 29, so she is not having that much BMI in which weight reduction is that much concern. As patient came to us for treatment, then we should start treatment along with this type of physiological management like dietary monitoring and lifestyle monitoring. If patient comes for preconceptional counseling, then only counseling suffice along with dietary management and lifestyle modification. But when she came with 3 year of married life, 27 of, year of age, and mild to moderate PCOS in which her cycles are not that much irregular, around if I am not wrong 35 to 40 days cycle, and
Definitely,
rest
Dr.
of
Sapar, definitely we are going to start medications, but according
yes.
to the American
I
Society of
separately,
Reproductive Medicine
Gayatri, I
guidelines.
would
Yes,
like to start patient for 3 month therapy, low dose contraceptive pills for regulation of cycle, first of
why?
all.
Patient wants to come to you for pregnancy.
But
Her,
normalization of hormone should be there
what is the criteria to start OC pills?
to normalize
Sir,
the
it's high LH.
hyperandrogenism.
Yes,
High
And
LH basis.
I did not written down the exact value of LH, but if patient is having a very hyperandrogenism, very high LH, you are right. But if patient is having borderline LH, just LH FSH ratio is high, what will you do, Dr. Rohit?
I would like, as far as Dr. Sappan has told, lifestyle
Hmm.
modification,
Hmm.
dietary, we can
So
take advice of dietitian.
we have to go simultaneously with counseling and medications.
Yes.
According to the guidelines in 2023, lifestyle intervention in the form of exercise, behavioral strategies, cognitive behavioral therapy, yogas with diet control is the first line management for any PCOS, whether she is coming for fertility or whether she is coming for the just for the PCOS problems. Okay, everybody got the point?
Yes, yes.
Okay, so these are the guidelines which are suggesting that weight loss of more than 5%, the people who are taking treatment simultaneously with weight loss of more than 5%, they got very good result as compared to the patient who are not concentrating on the lifestyle modification and weight loss. Okay, so these all are the non-pharmacological therapy we must keep in our mind, that we have to advise them about avoid smoking, avoid caffeine, nicotine, alcohol. They have to take proper sleep. They have to develop healthy eating pattern. They have to use non-processed foods, vegetables, nuts, healthy source of proteins and plant oils, and they must have to involved in any type of the physical activity that they can do, and they must have to relieve the stress. And as a gynecologist, we should be there to relieve their stress, as Dr. Sampath Kumari ma'am and once BN Chakravarti sir also has said that lifestyle modification is the first line. If someone will ask them what is the treatment for PCOS, they will say lifestyle modification, and lifestyle modification. Am I right, ma'am? I think ma'am is
Yes,
not there.
yes, sir.
So these are the recent guidelines. And our healthcare professional also should be teach regarding this, that they have to take care of all these things before starting any treatment. So now, you have counseled everything and you want to prescribe medicines. Which oral ovulogens you will prescribe? Dr. Hussaina is there?
Yes, sir. Yes, sir,
Yes,
I'm
ma'am.
there.
Okay,
Yes,
now
sir.
patient wants treatment from you.
Yeah.
You have
So,
counseled everything. She is ready, and now
yeah.
she wants treatment.
Yes, sir. So before ovulation induction, we should have done the tubal patency test as well as the
Tubal
husband semen.
patency test is normal. Husband semen
Yeah.
analysis is normal.
So after that, we can start with actually we can letrozole is preferred, but it's not licensed. So
No,
we
it is
can
licensed.
no. Okay, yeah. In UK, it's not licensed.
Okay.
So letrozole we can give 2.5 mg up to 5, or we can give clomiphene starting at 50 mg. So we can give for 6 cycles, and
What will be your preferred choice? I am
we
asking.
can
Patient is asking you.
yeah clomiphene we can start.
Any other panelist differ with the Dr. Ushena?
Sir, letrozole, sir. Letrozole will be first choice, and we can give up to 6 cycles.
Dr. Sapan,
And
you are agree with letrozole?
Would
Dr. Sapan.
I would prefer to start the in this kind of scenario with clomiphene citrate, as
Okay. Dr. Rohit.
as clomiphene citrate is a powerful ovulation inductor compared to letrozole. So uh, uh, that will give a good size of follicle.
Dr. Rohit.
First line of management, letrozole.
Okay. Dr. Ravi Sarkar.
The letrozole. I'll start
And
letrozole patient.
okay. Any other panelist? Okay. So these are the ovulation induction drugs available in different forms with the adjuvants. But according to the recent 2023 guidelines, letrozole should be the first line pharmacological treatment for ovulation induction in infertile and ovulatory women with PCOS with no other infertility factor. Okay.
yes,
So now I will come to Dr. Avi Sarkar. Dr. Avi Sarkar,
Yes, sir. Yes, sir.
you are starting letrozole. Which other medications you will use with letrozole, or you will give only letrozole?
Sir, as this patient, her BMI is also not that high. She's in the overweight category. Like only letrozole can also be tried, but along
Okay.
with letrozole, like we can also add other agents like inositol can be added, or
Okay.
metformin can also be added in can be added, which can help in enhancing the effect of letrozole. So it depends, like based upon personalized decision, depending upon the antral follicle count and all those things, like we can decide whether to add other agents or not. But
Okay,
only
done.
letrozole can be tried in the patient.
What is the dose of letrozole you are using?
Sir, I generally start with 5 milligrams, but 2.5
Okay.
milligrams can also be started.
So the guideline suggests that as low dose as you can start first cycle, then you have to increase according to the uh, next sonography or next ovulation results of that patient. So these are other guidelines which are suggesting that clomiphene citrate alone or metformin alone is much better, is not used, rather than you have to use clomiphene citrate with metformin if you are using clomiphene citrate in the cases of PCOS, because there are the chances of clomiphene citrate resistance is as high as 20% in cases of PCOS. And why letrozole is preferred as compared to clomiphene citrate? Because effectivity is okay, but the benefit is in clomiphene citrate you will get multiple follicles and there are the chances of multiple pregnancies. Clomiphene can cause antiestrogenic effect on the endometrium, and that can lead to the more monitoring at the time of the follicular study. Okay. So apart from the guidelines, these are the dose schedule of the clomiphene citrate. If you are using clomiphene citrate, how many cycles you will give, Dr. Sapan? And which dose? Dr. Sapan,
Hello. Yes.
you are using clomiphene citrate, so you will start with which
Yes.
dose and for how many months?
Start with 50 milligram per day from
Hmm.
second day onward, second to sixth day for 5 days. And
Hmm.
if the growth is not proper, then in next cycle we can go up to 100 and maximum up to 150 milligram per day.
Very good.
So
So this,
we need to monitor the size of follicle and simultaneously the endometrial size, because the side effect is thin endometrium.
okay.
Anti-androgenic activity is there. So
Okay.
we need to balance that.
So this is the reason why most of the studies suggested that to use letrozole.
Dr. Franz,
Okay.
can I enter? Can I have a
Doc,
comment?
yes, sir. Please.
Yeah. See, I have slightly different point of view, Dr. Franz. See, what
Yes.
happens is letrozole 2.5 is the only dose which is recommended by FDA. All right.
Yes.
Anything more than 2.5 is not recommended by FDA. One part.
Yes.
And second part is when we increase the dose of letrozole from 2.5 to 5, the advantage of monofollicular growth of follicle goes away.
Yeah.
The
But
advantage
there are the cases which we have seen that we have to increase the dose. In particularly, there are two other protocols. They are not approved, but many of the gynecologists are using. That is step up and extended letrozole protocol.
I understand. I know that. The only
Yeah.
thing is, one, it is not approved by FDA to use more than 2.5. Second
Hmm.
is the advantage which we are always talking of as a monofollicular no growth
Yeah.
of
Yeah. Yeah.
letrozole. That goes away if you increase the dose.
Dose. Definitely, sir.
So for me, clomiphene citrate still holds number one position. I don't know. This is against the guidelines, but this is
Yeah, yeah.
how I am.
Our particular private practice or our experience also matters sometimes when so we are dealing with the patients. This is a subjective thing that I am comfortable with letrozole, someone is comfortable with chlorine citrate.
See, no, Dr. Fraz, what happens basically is when the literature came that letrozole is say drug of choice in PCO. So if they then not many studies were there, and then this second part which I'm telling you is not never projected that advantage if you increase the dose of monofollicular genesis goes away.
Not in all cases, sir. Particularly in a step-up protocol, I have seen that. But in extended let we have to use sometime extended letrozole protocol that I'm discussing in this case. Like the same patient, you have used 2 cycle of letrozole. There is no ovulation, and patient is not willing to go for the gonadotropies. Now, what will you do for any of the panelists?
That is what I'm telling you. See, this advantage which we are always talking of letrozole, that goes away. Now, either once you increase the, I don't say never, don't increase. My point is, you can increase the dose, that is okay. But that advantage which we are getting of a monofollicular genesis goes away. So it is not a bad idea. And then the anti-estrogenic effects of clomiphene are not in all patients. That
Not
is
in all
again.
patients. I have seen
Sir,
multifollicular growth in many of the patients with chloroquine citrate. Since
Yes.
then, I am very much comfortable with letrozole, and even if I have to increase the dose or double the dose up to 5, I haven't seen that much of multifollicular growth. So this is my experience, sir.
No, this is what I'm telling you is what literature tells me.
sir, may I answer that question? Uh,
Yes, please.
if letrozole fail, sir, according to new guideline, we have first line letrozole and we can give up to 6 cycle. And
Yes.
if patient does not ovulate, then we can give her option of GnRH agonist or laparoscopic ovarian drilling. and her third option will be IVF. But in India, we we have permission to use letrozole. So in India, many of us are using extended step-up protocol of
No,
letrozole,
madam, sorry.
and
In
we
India,
use
we
8
also
to
do
10
not.
days.
In India, we do not have permission to use more than 2.5. We are using, that's a separate story.
Yes, sir, but 2.5 mg for 10 days, many of us are using, and we got ovulation, even monofollicular ovulation we are
Madam,
getting.
please, there are two aspects. One is what we are
Yes,
using is a different story. What is recommended is the second story. And what is approved
yes,
is a third story.
Yes. Sir is telling that it is not approved. Recommendation is a different thing, and we are using is a different thing.
Yes.
yes, sir. Agreed,
Exactly.
sir.
So,
Okay.
so one
So
question. One question.
Continue, please, continue.
Yes,
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 sir.
one question. Sarfraz,
Ye-
one question.
Yes, sir.
So, do you recommend estrogen in this ovulation induction?
I am coming to that part of the talk discussion in next few slides, sir.
Okay,
Okay.
come. Yes, continue.
Okay. So this is the scenario. This patient did not ovulate with 2 cycles of letrozole. Any of the panelists can find the way for this patient. Dr. Avi Sarkar. Dr. Avi Sarkar. Dr. Hussaina. Dr. Sapan. Am I audible?
Yes, sir.
Yeah. I think you are only there. So you can answer this question.
Sir, if she is willing, we can step up to gonadotropins. And
She
as
is
you
she,
have
she is denying. She is denying for gonadotropin. She is from the poor family. She don't want to go for the gonadotropins.
Why we
okay, sir.
cannot start
So,
clomicytrate as option of letrozole?
yes, sir, we can give
Yeah, you can start.
Huh.
yes, sir. With metformin, sir, because BMI is on higher side,
Yes, you
and
have to add some adjuvants.
Hmm.
yes, insulin
Either you,
sensitizer.
either sir is not agree, but this is my protocol that you have to increase the dose of letrozole up to certain extent, or you have to give extended letrozole protocol. I am using sometimes step-up protocol. That also sir will not agree, but I am using and I am getting some results with step-up protocol in a cases of refractory ovulation with the normal dose of the letrozole. Anybody is using dexamethasone?
No.
Yes, sir. Isolone is good because, as you explained in previous slide, that ROS may be a cause, and these patients are in chronic inflammation. So we can add for complete cycle, like Isolone we are using. So
So what could be the reason of letrozole failure in any of the patient? I'm not asking about the same patient. What could be the reason of letrozole failure? Patient is not ovulating, not getting, you are not getting that much big follicle with letrozole with either the dose of 2.5 or 5 milligram. So what could be the reason?
sir, she may need higher doses or gonadotropins. Like cohort selection is the main thing we need
Yes,
to do.
you
That's
have to
why
look
maybe
for the
she's not.
LH, particularly in
Yes,
this
sir.
type of patient, because hyperandrogenism and high LH may lead to the failure of letrozole ovulation induction. So some people are using, some people may stop the letrozole. They have to come down the LH. For that reason, they are using OC pills for 1 or 2 or 3 months, either continuously or sequentially. And that type of patient can get a good result afterwards.
Yes, sir.
So this is the importance of using OC pills in high LH cases because high LH is detrimental for oocyte. We have to bring down the LH up to a certain level. We can use continuously for 2 or 3 cycles, or you can use cyclically. Dexamethasone you can use up till the follicle get 18 mm. Extended letrozole protocol, everybody knows how to use. Step-up protocol, not approved, but we are using. Some people are using to meet the threshold and to extend the window of follicular process. Disadvantage, as sir has already mentioned, multifollicular growth is there. So the same thing happens with the clomipene comes again. What other adjuvants you will use, Dr. Sapan?
Inositol is
Yes. Yes, we can use myoinositol because it is a very good
Hello,
insulin
sir.
sensitizer.
Surfaras,
Yes,
I am using myoinositol.
yes, we can use myoinositol because it is a very good insulin
40
sensitizer.
to 1. This is definitely where that myo and decairon.
Yeah, metformin
recent,
we can
recent
add.
guideline does not support inositol, but we are using it since years, so we don't know. Just
I'm coming to
explain the condition.
I'm coming
Yes.
to the guidelines. These are the few insulin sensitizers in a cases of insulin resistance, and acetylcysteine, myoinositol, metformin you can use. Lastly, I will come to the guidelines. Before that, the same patient, you have given extended letrozole. Day 8, you have examined there is no dominant follicle. Day 10, you have 14 follicle with endometrial thickness 5 Day 12, you have 16 follicle with endometrial thickness 6 So, what should be in your mind after seeing this patient on day 12? What will ring up in your mind that what is going wrong or everything is okay?
Endometrial thickness, sir.
Endometrium
Yes,
thickness, you are worried about that? So, what will
yes,
you do?
yes.
You are going to call the patient on day 14. Day 12, patient is having 6 endometrial thickness, 16 follicle size. So, what will you do? Anyone?
From next cycle, we can add estradiol.
You will add estradiol. Anyone else has any different opinion? Sir, you can also please give your experience here. Arun sir.
We
Arun
can
sir?
call her on day 14 again to look for
Yes,
growth,
very good.
because it's on successive day 10, day 12, it's increasing in size, and endometrium is also growing.
Yes. So at this juncture, on day 12 with 16 of follicle, you need not to worry about the endometrial thickness. Okay. Because there is no need to add estrogen if follicle is growing synchronizingly and endometrium is also growing synchronizingly. Now, some different cases that if patient stays in village and cannot come for the follicular study and patient is having AMH of 9 and both the ovaries are bulky with almost 15 follicles. What other advice or what other mode of treatment you will advise for that patient?
LOD, sir. This is perfect
Very good.
treatment for her.
Anybody is doing LOD right now from our panelists,
Ovulation.
from our expert?
Yes, sir. We are doing.
No, I think.
Not routinely doing nowadays because not highly recommended. But yes,
Yes.
when we used to do, I mean, there were good results. It is not like that it should not be done, but yes, the results were definitely good.
Yes. So according to the guideline, laparoscopic ovarian drilling could be second line therapy for women with PCOS who are anovulatory, infertile, with clomipene cited resistance and no other infertility factors. But you have to keep something in mind, which type you have to select the patient very curiously that younger age with normal BMI, lesser duration of
In
infertility, high LH, high AMH, or high androgen index. This type of patient will get good result with laparoscopic ovarian reading. Advanced age patient, longer duration of infertility, obese patient will not get that much good result. What precautions you have to take precautions. You have to prevent infection. You have to follow the rule of 4, and you must
food.
have to know that the effect may last just only for 6 months or sometime it may be for 2 years. Again, the patient will come with the same hyperandrogenemia, and you have to treat her before her androgen start to increase. Now, the same patient, letrozole tried in all form of extended to step up and everything. Patient got fussy, lost to follow up. Again, after 6 months, she came to you. She put on little weight. Now she is willing for gonadotropin and IUI. And you have started with the letrozole for 5 days. How will you give gonadotropin for this patient? Patient wants to IUI. Anyone? Avi Sarkar? I think he left.
In this scenario, I would
Yes.
like to go with FSH.
Okay.
In combination with letrozole, so
Hmm.
from day 2 to day 6, letrozole, and from 7th day onward, I will
Hmm.
start with 75 international unit of FSH and monitor her follicle along with endometrial thickness.
Okay. Guideline is suggesting that you can use any of the gonadotropin. Previously, that was a dictum that any PCOS patient we are using only recombinant FSH, but it is not like that. Until and unless LH is very high, you can use any of. This is your choice of treatment. So now you have started gonadotropins. Let's assume recombinant FSH. Day 7, all follicles are 8 to 9 mm. Okay. Now patient is coming on day 10. You have seen 3 to 4 follicles of 14 mm. You have started recombinant FSH, minimal dose 37.5 or 75. What will you do? Day 10, 14 mm, 3 to 4 follicles. Any of the panelists?
We can continue with stopping the dose and let it grow naturally for 2 or 3 more days. At this
Okay.
stage, if we feel that chances of OHHS, then we can add antagonist also, so that the premature rupture of follicle and that not happen.
Also, if we are planning for an IUA and we are expecting 2 or 3 follicles, we can simply wait and watch also.
Very good.
Let it mature on
Yeah,
its own.
1 or 2 follicles may get mature after 14 mm, and then we will get good results. So there is not much worry if you are having only 3 or 4 follicles of 14 mm. Okay.
So nothing. Just wait and watch and close monitoring.
Yes. Now, fortunately, on day 12, other follicles got atretic and you got single follicle of 18 mm with endometrial thickness of 8.5 millimeter. Which trigger you will use?
Agonist, sir. That's we should avoid.
Beta HC.
We need to join. So 56 already.
Yeah, ma'am. I'm just completing one panel and I'm in different webinar coming after.
Yeah, but
10
then
minutes.
yeah.
Coming. So we have to run fast because I have to go for another webinar at 6 o'clock.
Okay.
Which trigger? We will go with like a
Agonist.
rapid fire round.
Beta HCG, 5000.
Beta HCG.
You can use.
Yes. Sir, just
There is nothing to worry. These all slides I have to skip off because we have to cover another thing also. For IVF, which type of protocol you will use if patient willing for IVF? Antagonist.
Protocol.
Everybody agree?
Yes.
You can diane regulate with OC pills or diane regulate with antagonist, right? Progesterone only pills also using right now. These are the guidelines for gonadotropin use recently in 2023. No gonadotropin is superior as compared to other. Uh, and if you want to use gonadotropin alone for the IUI, you also can use either gonadotropins or laparoscopic ovarian surgery could be used in women with PCOS who are anovulated infertile with concomitant cited digestion. This is also in the guideline. And gonadotropins could be the second line pharmacological therapy with PCOS with no other infertility factors. What are the criteria for OHSS in PCOS? Fast. How many follicles? Anyone?
So if she has a previous history of
I'm talking
OHSS,
about IVF, huh?
yes, sir.
Yeah.
And if he
So more
have
than
used
17
oxygen,
follicles,
yes,
estrogen, you have to do E2 level.
yes.
Okay. So according to the guidelines, GnRH antagonist cycles are superior over the GnRH agonist cycle in control ovarian stimulation to prevent the OHSS. Triggering final oocyte maturation with GnRH agonist and freezing all suitable embryos is recommended according to the guidelines in 2023. Choice of follicular stimulating hormones, any exogenous luteinizing hormone should not be routinely used. As I have mentioned, choice of these all are the studies showing that women undergoing control ovarian stimulation with antagonist protocol followed by the frozen embryo transfers are getting much more good result without OHSS. And embryo from the woman with PCOS grew faster until the ninth stage, and women with hyperandrogenic PCOS until the morula. So this thing also you have to keep in mind. This is the one study is showing that freeze only what to do for prevention of OHSS. Consider for the freeze only cycle. One new thing is coming in the guidelines that PCOS patients can benefit from the in vitro maturation. Many of the centers are following this. Which type of luteal phase support you will give for the patient with IUI, agonist protocol, IUI, agonist trigger, and lateral and gonadotropin stimulation? First, anyone from the panelist? When will you
We
start
can
luteal
do
phase support?
On 25th day of menstrual cycle.
You have, if you are doing IUI, then you have to start from the second day of the IUI, luteal phase support.
Okay.
And you have to continue. There is no data suggesting that the clinical pregnancy rate were equivalent, even if you are giving progesterone supplementation till 21 days or till 12 weeks after the pregnancy. So you have to decide according to the patient to patient. These are the FOXY guidelines. Lateral is the first line of treatment. IVF possibly is the third line of management. Combination of metformin and myoinositol demonstrate the efficacy in improving the clinical pregnancy rate. So, any of the question from the panelists before winding up?
Sir,
Any
estrogen,
any
sir,
suggestion from the estrogen only for IVF patient?
okay, sir.
Because endogenous estrogen is there always, even if your endometrium is little bit thin. Little bit thin means maybe 6 or 6.5 or something. Okay, so nothing to worry up to 6 mm of endometrium. We have to look for the Doppler. We have to see the PSV. Okay.
And how good is that idea? There are, like, I've seen prescriptions, people writing 3 days estrogen from day 8
Nothing.
to day
No.
11. So, like, what is the whole point? Is that, like, workable?
It is not workable. It is not scientifically proven, or it is not recommended by any of the guidelines.
Sir, one thing I want to add, as you
Yes,
suggested,
please.
according to guideline, freeze all is now recommended. And in PCOS patient, we have to take care of, like we should use only single embryo, like single embryo transfer to avoid OHSS.
It's advisable.
Yes.
It is recommended and advisable also.
Yes.
And you have to think about OHSS also. That's for that only people are turning to freeze-all side to prevent secondary OHSS, because secondary OHSS is much more dangerous than primary
Much more
OHSS.
than, yes, sir.
Okay.
Yes,
Sampat Kumari
indeed.
ma'am, shall we wind up?
Fantastic data set for us. Yes, fantastic. Very fast and the fruitful panel. Thank you.
Because I have to go for another webinar.
Yes, sir. You can leave. We will finish with the vote of thanks.
First of
Thanks
all,
to everyone.
thank you very much. And I am contesting for this post. Please nominate me. Only 10 days left.
Yeah.
Those who have already nominated, thank you very much. Those who have nominated another person, also thank you very much from that side. And those who still not nominated, please nominate me.
Nominated already. All the
Okay,
best.
thank you. Thank you,
Thank you,
ma'am. Thank you, everyone. Thank you, Madhumita.
Thank you, sir.
Thank you.
Thank you so much, sir.
Thank you.
Thank you
Thank
very
you,
much,
all
sir.
the
Thank you, all
panelists.
the
Thank you.
Yes, sir. Thank you so much, sir.
Thank you.
Thank you, sir.
For all the president, secretaries, moderators, Arun Arora, Sarfaraz, and all panelists. Thank you. Thank you to Madhumita and Radhika for MOC.
Thank you.
Thank
Thank
you.
you,
All
ma'am.
of you
Thank you so
vote
much.
for Dr. Sarfaraz and Arun Arora. Thank you.
Yes, ma'am. Thank you, ma'am.
Thank you, ma'am. Thank you so much.
Thank
Thank
you.
you.
Thank you, Saidi. Thank you.
Thank you, Sahiti.
Thank you.
Ramesh sir, thank you, sir, for being
Thank
the chief guest. Thank you,
you.
sir.
Thank you, ma'am. Enjoy it.
Enjoyed. I'll come to Jammu in person.
दूसरी बार
Afterwards.
उठा रहा है.
Yes, sir. Thank you, sir. Good
Thank
night.
you, ma'am.
Thank you.
Thank you.
Good night.
वहाँ से निकलूँ ना मैं. लीव का है लीव. दूसरे में तो अपने बोलने का नहीं.